Good morning. I'd like to welcome everybody to this morning's residence presentation. Today it's going to be Dr. Amelie Müller, who's going to talk about postoperative delirium and the necessary treatments. And this talk will be accompanied by Professor Urs Schwarz, who's a staff neurologist who's going to help us with a discussion regarding ideal management and therapy of the delirium. Thank you very much.
So, imagine we have a 73-year-old patient who had an emergency operation. It was a big operation with a big laparotomy. The length of the operation was about 6 hours, and today is the second postoperative day. During the day, the patient was a little bit sleepy, but you could wake him up, but it was difficult. And now during the night, the nurse is calling and he's agitated. So first, what is the definition of the delirium? The delirium here, the ICD-10 definition, is a perceptual and attentional deficit. That means if the patient has problems to focus. Then he can also have a cognitive deficit. That means if he is disorientated regarding time, place, or persons. And he can have psychotic features as hallucinations. Then he can also has disturbed psychomotor behavior. That means also if there is a switch between hyper or hypoactivity, but we will talk about this later. Then a disturbed sleep and wake cycle. And the most important point is acute beginning with a fluctuating course. This is really the most important point, and we will also talk about this later. So the delirium is a form of encephalopathy. From the epidemiology in population, the prevalence is about 0.2 to 2%. In hospitals, around 56%, and in intensive care, it's way higher, of course. It's 70 to 87%. The mortality, as you can see, there's a big range, but there are a lot of publications, and also the patients are really different. That means some patients are operated or had different risk factors. So, but it's a big number. It's between 22 and 76%. So, I don't know if you remember, before we always learned that there are subtypes, that there is a hyperactive and a hypoactive or a mixed type of delirium, and that there is a productive and unproductive type. That means with hallucination and without hallucination, but that's wrong. It's always a mixture between everything. From 1 second to another, the patient can be sleepy, and the next one he's agitated. 1 second he has hallucinations, and the other he hasn't any. So, back to our patient. As we said before, 73 years old, big operation. It was an emergency operation. Now it's the second post-op day. During the day, the inflammatory parameters were high, and now he's agitated. So, what kind of questions do we have to ask ourselves as doctors? We want to know, has he alcohol addiction or history that he drinks a lot of alcohol? What kind of medication does he take? What kind of comorbidities has he? Are there any other differential diagnoses to delirium that we can, And we also have to think about hallucination. If the patient is looking around and doesn't have a fixation, or if he is going up in the air or something like this, we also have to think about a hallucination. So the next point, what kind of risk factors or etiology can lead to a delirium? There are different etiologies or risk factors, the age, stress also, or if the patient already had a delirium, a big operation or trauma, if it was an emergency operation or if it was very long the operation, if the patient has a lot of pain, comorbidities, and also from the etiology, big points or important points is toxic, that means drugs or an alcohol abuse, but also metabolic and endocrine, such as hypo or hyperthyroidism, uremia, hypoammonemia, dehydration, electrolyte disturbance, and such perhaps as here, a septic patient that has fever or also hypoxemia can lead to a delirium. Now we wanted to ask ourselves, okay, what is with the patient? And we said, okay, we want to know if there's any alcohol problem or not. So we do the CAGE. The CAGE is, the C stands for cut down. That means if the patient ever had the impression that he has to reduce his alcohol consumption. A is for annoyed. It's if someone annoyed you because he criticized your alcohol or drinking behavior. G is for guilty. That's if patients ever felt guilty after drinking alcohol. And E is for eye-opener. It's when you wake up and suddenly you feel the urge to drink alcohol. So if the CAGE is higher than 2, then you have the suspicion that perhaps there is an alcohol problem. So if you have this suspicion, then you have to take a closer look to his medical and alcohol history, even perhaps ask relatives or friends if the patient is okay with it, if there are any things that are a little bit different or special. Perhaps you can also do a lab with transaminase, the MCV, MCH, the pancreas amylase, or cholestase. Then we said also that we wanted to know if the patient does take any drugs that can lead to delirium. So the medication or drugs that are important for us, because there is a long, long list, so it's just some of the drugs, are antibiotics, antidepressants, antihistaminica, beta blocker, benzodiazepines, immunosuppressors, ondansetron, and tramadol. So during all this thing, we can do also screening methods. These are the nurses that do the screening methods. First, they do a DOS, a delirium observation screening scale. So if the DOS is higher than 3, I will tell you later what the DOS is, they will do the MSQ and the CAM. The MSQ is a mental status questionnaire, and the CAM is a confusion assessment method. So the DOS is an instrument with 13 verbal and non-verbal behavior criteria, and the DOS gives a rough estimation of the total picture. So it's an early recognition for patients in non-intensive care. I don't want to talk about the patients in intensive care, but with intubated patient or in patient intensive care, you can also do, or they do the RASS, the Richmond Agitation Sedation Scale, and the ICD-SC. So here, after the DOS is higher than 3, as I said before, they do the MSQ, and the MSQ is to check the orientation and the concentration of the patient. Later, they will do also the CAM. The CAM is also to instrument and to diagnose the delirium, and if the CAM is positive, then you have a high suspicion that there is a delirium, but you also always have to think about the differential diagnosis also. And you can do, or you should do, a lab, and the lab also the nurses can do. So here at the USZ, we have our own algorithm. It's also here if you want to take it later. And it's a difference between patients with an alcohol problem or history and without. So, as we said before, we do always the cage. It's always the physician, I forgot before to tell you, it's always the physician in the first 24 hours that has to do with every patient a cage. So if the cage is below to 2, but he is agitated or you think there is something, perhaps he has a delirium, then during all this time also the nurses, as I said before, do the dose. And if the dose is higher than 3, they do the CAM and the MSQ. And they will also do a lab. And of course they will call us and say, okay, we think that the patient has a delirium. So if now we are sure that there is a delirium, then of course we have to think, why is there delirium? And here also we can have a fluctuation. Our patient has high infectious parameters. It was a long operation. It was an emergency operation. And perhaps the patient is septic. And so this perhaps is now the reason why he is delirious. And next, we treat him with antibiotics. And perhaps that's the next reason why he is delirious. And perhaps the antibiotics make a renal failure. And that's the next reason. So there's always a fluctuation of the symptoms, but also of the etiology. So we have to treat, of course, the reason why there's the delirium. And we have to do a treatment with medication if there are also any hallucinations, but we will talk about this later. If there is an alcohol problem or the cage is 2 or higher than 2, then, as we said before, we have to talk with the patient, perhaps with the relatives, do a lab, and we also have to talk with the patient to put some rules. That means it's really forbidden to give the patient alcohol, and we have also to do a little note in the kissing. So, to the pathophysiology of the delirium. Here you can see the brainstem, and in the pons you see the reticular formation. The reticular formation coordinates all signals and neurotransmitters. That means the formatio contains cells that release all kinds of neurotransmitters. Here are some examples of the most important that are also really relative for the delirium. Yes, they release all kinds of neurotransmitters and spread them in the whole brain and influence the activity of the cortex. And as we said before, the delirium is a form of encephalopathy. So the main problem of this encephalopathy is the dysfunction of astrocytes. I will show you the next picture why the astrocytes are important. And also the disbalance of the neurotransmitters are the reason why there can be problems in the vigilance and the lucidity. So here you see a presynaptic neuron and a postsynaptic, and here the astrocytes. I forgot to tell you before that here perhaps the glutamate has an excitatory signal. So here in our example we talk about glutamate. So the presynaptic neuron releases through the vacuoles the glutamate. And then the postsynaptic receptors, they take the glutamate and there will be a release of action potential. So the astrocytes are like a vacuum cleaner, and they take back the glutamate and they transform it to glutamine to reactivate it and to give it back to the presynaptic neurons. So it's like a circle. So if the astrocytes, there is a reason why they don't work at the beginning. Here there is too much glutamate. And after some time there will be less production of the glutamate and we don't have enough. So what can be the problem, or what can be the reason of the swelling of astrocytes? We talked about it before. It can be perhaps ammonia due to bleeding. It can be through sedatives such as benzodiazepines. Hyponatremia can also lead to astrocyte swelling or dysfunction. The pathophysiology of syndrome is different. It's also the problem is also the disbalance between the neurotransmitters. In A, you see who doesn't drink any alcohol. So there is GABA and glutamate. GABA is an inhibitor, glutamate is an exciting one. A person who isn't who drinks alcohol, there is more, and so the patient or the person, and also euphoric. It's a chronic drinker. There are less receptors that are working, and also another problem is that the regularly alcohol consume can lead to more distribution of the glutamate. So you have to drink more alcohol to have this sedative, euphoric result. So you have a bigger tolerance to alcohol. So in D, you see a patient with a withdrawal of alcohol. So you have much more glutamate because it was much more released and you have less GABA. So we said before, we always have also to think about differential diagnosis list. But here you have to think about a stroke or encephalitis, perhaps if the patient pain, neck or something, meningitis, and patient also. Our patient, the 73-year-old man, second emergency operation, lung operation, and parameters, and his eyes are wandering around. When you come, he's really agitated and he wants his drains. So what would you do? What is treatment? Okay, we know now. So for the is our management, how we treat a patient with the delirium. So we have 3 big points. Then the treatment and the IMC and the ICU. Talk about the ICU treatment. So if we think now the patient has a high risk, because he has a lot of risk factors, or the doctor, something like this, then you can perhaps with dipyperon with a low treatment. So give, if he has anxiety like this, Temesta. If the patient is really so you have to make a differentiation, cooperative or not cooperative. If he is a little bit more you work more with, you can give also, if there's sometimes agitation, but there's always a fluctuation, the dipyperon. And he's more agitated and sometimes that means you work first with the dipyperon because more agitation, and you can give any hallucinations. If the operative and dangerous for himself or for others, you can work with the dormicum perfusor. In treatment, the dormicum perfusor, it's only a solution for if it's during the night on IMC or even a normal, then you have to stop it at 6 o'clock and to see again what kind of problems are there, what are the risk factors, patient, why does he have a delirium, etc. For us also to know what are the effects of the dormicum. It can be bradycardia, hypotension, or rest. So if you work with it, you always have to know what is the antagonist. The antagonist of the dormicum is senile. It's called annexate in our C. So we said before the alcohol problem that the KH was below than 2. If it's 2, you suppose even that perhaps he has alcohol abuse syndrome. So here the treatment, and also here we have a prevention if delirium. So we can do trimester and and we always have to give them the thiamine and folsäure, always. I think that it's often forgotten to the vitamins. And delirium, then we can work with trimester. There are any hallucinations, then we can, and of course, all, and if he's uncooperative, other treatment form. So what can we or the nurse and the delirium? We can reduce the patient, we can try to equilibrated nutrition, then of course management, then regular mobility and is very important. Patient. Why is delirium so important, or why is it so dangerous? Because of course it can lead to incompliance if the patient doesn't take his medication, if he pull out then the hospitalization length, of course, is getting longer. He can fall. It can lead to long-term cognitive deficits, and it even can lead to mortality. So here you see a study where you can see that patients with delirium stay longer in hospitals, as you can see. And here you see that the survival rate of patients without delirium is higher. And what I didn't know, what I think is really interesting is also that here you can see that in the studies that had a long follow-up, they showed that after discharge, 1 year after discharge or longer, most patients showed cognitive limitation such as memory dysfunction. So thank you, and thank you for your support.